So I'll talk about the arthroscopic iliac crest with the non-metal fixation. So I have no conflict in this talk. So Marcus and his group published in 2014 his series in arthroscopic iliac crest, and at that time there was metal fixation and with a very good short-term follow-up. Then our technique published with Dr. Hashim from Spain in Barcelona with arthroscopic iliac crest with a cerclage fiber tape, so without any metal implants, and it's just a malleable soft tissue fixation. So usually the indication for arthroscopic iliac crest, it's exactly like any bone procedures, always when you have a glenoid bone deficiency or when you have a subcritical bone loss. And this is a new concept that even if you don't have 13% of the glenoid, still if it's less than this, still in a high athletic patients, you need to do a bone procedure. And also you can extend this in a big hill sac, because usually we have wrist 2 centimeter by 2 centimeters. So we add 20 millimeters, so we can add like another glenoid in the anterior part of the glenoid. Then we can extend this in a bad anterior complex. So usually in our countries, some patients present very late, so we can't find any labral to repair. So we did in the past what we call a capsular tenodesis. So if you have a very bad anterior tissues, even if you don't have a severe bone loss, in high athletic patients, always the bony procedures, it's a winner for these patients, and also for a Hagel lesion. Still, I'm a big believer that in Hagel lesions, in a professional athletes patients, you need to add a bone for instability. So basically the technique, this is a anterior reference from posterior portal, and this is an older version for this guide. We developed a new guide. Then we drill a parallel cannulated drill bit, and this is almost like 2.4 millimeter. Then we retrieve the retinal wire from the interval. So you can see that the interval, the wire through the interval, we don't go through the subscap, and this is a little bit different from any hard fixation, unless if you use a Halifax portal, which is described by Evelyn Wong, and this is a completely different issues. So we don't want to go through the subscap, we don't afraid about the axillary nerves all the way through the interval. Then we should have a very strong suture material to retrieve the cerclage fiber tape. Then we shuttle the fiber tape through the bone graft itself from in, out, out, in. Then we deliver the graft through the interval. So it's very important, and this is the most demanding step, that you can put a big piece of bone through the interval. So we have some tricks to avoid any struggling in delivering this bone. Then at the end we do sequential tightening of the tails, and we put a tensioner. So at least we need 40 to 50 Newton tension. Then we cut the tails of the cerclage fiber tape and done for the procedure. So usually our position is a lateral decubitus. Why? Because at the same time we can harvest the iliac crest, and always in the interarticular part we have a very good distraction, and we can see 360 around the glenoids when you have good traction. So this is exactly what you do in non-union fractures. So it's a tricortical iliac crest. We take 2 by 2. It's a big piece, as I mentioned before. So even if you have a bipolar defect, that will do a job. Then we drill 2 tunnels. It's a very small tunnels just to deploy the cerclage fiber tape. And there's a 2-way. Either you do a decortication, because it will be interarticular, and this will end with the fiber cartilage, or you just fix the piece and put the labrum in the top of the glenoid, so it will be extraarticular. So usually we do a decortication to have a fiber cartilage in the iliac crest itself. So this is our technique. So this is the right shoulder, and we are viewing from the anterior superior portals, and we are working from far inferior portals. So we decorticate and prepare the bed for the graft, and we need to take out all the anterior labral complex. Always we do measuring in every single shoulder instability case. So we have to measure from posterior to anterior to make sure the size of the glenoid. And this is 2 millimeter apart. There is a different depth gauge. Then at the same time, we introduce a needle from the posterior portal, and it will be parallel to the glenoid to make sure that the guide will fit parallel to the glenoid. It's very important when you put the guide and put it from posterior, and this is the older version as I mentioned. There's another one. It's anterior reference. You need a 5 millimeter below the glenoid surface, because if you drill more than this, the graft will be medialized, and you don't need a medialized graft. So make sure that you drill 5 millimeter, 6 millimeter, not more than this. So this is 2 cannulated drill bits. Then we retrieve a retinal worse. These drill bits, actually, we use it in a dog bone for the AC joints, sometimes in the ACL. Then we retrieve this through the interval, and we need a very strong suture material to retrieve the fiber tape, because it's very strong. And after retrieving the fiber tape, we have to open up the interval. And this is the tricky points. We need to open all the way at the interval, because we have a big piece of bone. So we need to open it, and we don't need any suture bridge. So we have to open it all the way down and make sure that your finger, and this is my finger here, it's inside the joint clearly. Nowadays we can over this by using a 20 cc syringe and cut it in half. I use it as a cannula, because in the market right now we don't have more than 10 millimeter cannula. So 20 cc syringe will do the job. So then you start to do sequential pulling in the posterior cerclage fiber tape. As you can see here, sometimes the graft will be flipped, so you have to have what we call a leading stitch. And this is exactly when you have a button in the ACL, you have a leading stitch that will pull the button all the way down. So sequential pulling back and forth, just to make sure that we deploy the graft all the way in its position. And this is the most demanding step in this procedure, because it's a big graft, as I mentioned before. Then after that, we have to make sure that it's sucked all the way in the graft, then start to do a tensioning. And as I mentioned, at least you need 40 to 50 Newton tensioning with a tensioner. After that, then you do half hitches, and that's it. Then you can see that the bone, it's a big piece, and it's almost flush with the glenoid. So we did some modification, as you can see here, that when you do a lot of pulling, the cancellous bone, there's like, we are afraid about the cutting through the cancellous bone, even if it's a tricortical. So we added a wedge plate, and this is, we use it sometimes in the open lateral J. So we put the tension in the plate itself instead of the bone. So this is, will distribute the tension in the cerclage fiber tape. And this is the X-ray post-op. You can see the piece of bone with the plate without any screw fixation. And this is a CT scan. We do 3 months, 6 months, 1 year, then almost like 2 years. So we've been using this almost like 2.5 years till now. And this is one CT scan for the plate, and this is another CT scan without plate. What about the range of motion? We don't have any obvious restriction for range of motion, even in external rotation. What's the advantages of this technique? Usually it's all arthroscopic, and still you can use it in any other autografts, in distal clavicle autografts or distal tibial allograft. Require a small drill hole, and this is, you're not afraid about cut through of the bone itself. Then we don't have any metal fixation. This is very important. It's a reproducible techniques that are easy. You can do revisions because it's suture material. Like when you do a cuff repair, so you just take all the suture materials and put another suture material. So what's the disadvantages? It's a demanding technique, especially when you deliver the graft, and always we have a graft side morbidities, and there's always a possibility of a wrong graft position. So Be careful that always you have to do your proper managements in the anterior glenoid, that you are 5 to 6 millimeter below the glenoid surface, and graft resorption. I think this is a problem in all bony procedures like a lateral J or iliac crest. So just one more slide, please. So usually the resorption in a tricortical iliac crest, it's if we consider this zone A, B, C, so most of the resorption will be in a zone C. So tips for this, we use sometimes a double posterior approach. We have to open the interval very properly and big opening for the intervals, and we use a very strong suture materials. What's the pitfalls of this? That always the capsular, anterior capsular complex is there, so sometimes this is, you have to take out all these tissues from your vision, guide position as I mentioned, and bad tunneling. So this is one of the systematic review for the arthroscopic iliac crest grafting. We don't have a long-term follow-up, so we have just a short-term follow-up with a very excellent results for less than 4 years. Thank you.